I want to say at the beginning that the lecture I prepared is extremely basic. It's like a teaching course on liver tumors. I'm going to try to assimilate into this how pathologists view cancer diagnosis, and even though liver is maybe one of the more difficult examples to explain how we make diagnosis, because we're not very good at it. We often make mistakes. It's not so simple like breast or so. But it's a basic lecture, and and I'm not going to talk about our own research. Maybe just mention there's no data slides from my lab. So if you expected something else, please feel free to do the more important things that I'm sure you need to do, even if that means going to Kumsitz and baking potatoes. It's very important and also very tasty. So liver tumors. And when we talk about liver tumors, like in every other organ system, we can define tumor lesions. We categorize them. You know, physicians in general. How many of the people in this audience are physicians or medical students? 1, 2, 3. You cannot. Okay. So all the rest are biologists, and
all the rest are physicians for mice.
Physicians, no, but I want to say, you know, when we teach,
and everyone has a liver.
Hopefully, when we teach in medical school, and we teach to PhD students, the teaching is different, because actually the way of thinking is different. This is why we need physician scientists like Ayelet and others in this audience. It's a different thought process. While for the physician, the most important thing is the end point, making a diagnosis and choosing the correct treatment. For the scientist, it doesn't matter at all, right? Making mistakes is probably the most important thing for a scientist. So it's different, and we have to think about it differently. But this lecture is, I'm going to, hopefully I will be able to try to convey the way that we think as physicians on how to help patients. And probably the basic, what would be, you think, how do we diagnose a patient with cancer? How the physicians, please don't answer. How do we do it? You know, 40% of the people in this audience are likely to get cancer during their lifetime. How would you know?
You become yellow.
Hmm?
You become yellow.
You become yellow. That's true. Sometimes there are you become very, very sick. You go to the physician. He sees that you're yellow. Now, for a physician, when a patient comes into a physician's office, and I must say another apology that is due. The ad says that I'm an oncologist. I'm not. I don't know how to treat cancer patients. I'm just a pathologist. Our job is different. But maybe to put things in perspective, how many oncologists do we have in Israel? Around? Give a number. About 150, I think, 200, something like that. How many pathologists? 110. 50% of our time is dedicated to cancer. So obviously there are other physicians that treating cancer patients, like surgeons and many others. But the burden of cancer work, of cancer care that is provided by pathologists, assuming that we are as hardworking as the oncologists, which if you would ask them, the answer to that would probably be no. I'm not sure that they are correct. So pathologists have a huge impact on cancer care. And that's everywhere. That's this ratio that I just described. That's worldwide. And I'm going to try to convince you how important pathology practice is for successful oncological treatment during the lecture, even though it is not the subject of the lecture, but that's like a secondary gain. So how do we diagnose a patient with cancer? If a yellow patient comes into your office, what do you think? Yellow like a lemon. Try to think as a physician, not as a scientist.
Ask him if he ate too many carrots.
If he ate too many carrots, well, then he would be orange, and really, you know, when you have too much vitamin A, you become more orange.
Oh, yeah,
so, in medicine, we have a way of thinking which is called differential diagnosis. If a yellow patient comes into your office, the first question that you must ask is whether it belongs to the category of silent jaundice or pruritic jaundice. Okay? If a patient feels well, you know, there is nothing. The only thing that the patient has, no fever, no stomach aches, no nothing, and he comes yellow into your office, the most likely diagnosis, in 97% of the time, would be cancer that is involving the main gallbladder duct. So it's obstructing the flow of bile from the liver into the into the bowel, and you become yellow. Your bilirubin levels go high. But if you have fever, then you would want to think about hepatitis, right? Any hepatitis, any liver disease can cause jaundice. So yeah, if a patient is suddenly very sick, but most of the cancer patients that we diagnose are not yellow. So what, you know, somebody does a chest X-ray. He does a chest X-ray because he moved to a new job, okay? And you see a mass in the lung. It's not supposed to be there. What is it? And so I'm not going to talk now about the lung, but on the liver. So most of the liver lesions that we see were incidental findings discovered because somebody looked at the liver for another reason. A patient has a stomach ache and somebody thought that these are going to be gallbladder stones and so on, or a CT for anything, and you see a lesion, a mass in the liver. And the normal liver is homogeneous, is very homogeneous, no mass lesions in it. So this is bad. Obviously, nobody wants to see a mass in their liver. And now you have to start thinking the differential diagnosis. And the differential diagnosis is ordered by different categories. And also the physician must make an order of first frequency, how common is a specific condition, and how important it is to diagnose it. Okay, there are diagnoses that you do not want to miss. When we teach this to medical students, the best example is if a patient comes to your clinic with headache and fever, what is the likelihood that this is acute bacterial meningitis due to meningococcus? Very low. Never miss this diagnosis. Never ever. Because if this kid is going to leave your clinic or your office or your ER and going to go home and tell him, if you feel bad, come back tomorrow, he's dead. Okay, so there are diagnoses you do not want to miss, but there are diagnoses that you must prioritize. And it depends on the frequency, on the importance, and also on our ability to treat it. Because if meningococcal meningitis was an untreatable disease, and it's not so bad if I miss it, but it's really a treatable disease, highly treatable disease at the very early stages, and late stages, you know, there's nothing you can do. So back to the liver. So this patient did an ultrasound of the abdomen, and the radiologist sees a mass in the liver. So what could these masses be? There are tumor-like lesions, masses in the liver, which are really not neoplastic. This could be reactive. I will show you a few examples. This is, of course, the best situation because it's a big relief. It's not cancer, it's not a benign tumor, no risk of malignancy. And then there are the tumors. So the tumors in the liver can be either epithelial, meaning tumors of the hepatocytes or the bile duct cells. They could be either benign or malignant. And there are non-epithelial tumors, mesenchymal tumors, which can either be benign or malignant. And of course, metastasis to the liver. So how do we make the diagnosis? There's this patient. It's a 42-year-old woman who has, and they did the ultrasound with a hypothetical diagnosis of gallstones. She has gallstones, but there is a mass in the liver, and now this becomes the more pressing issue. So what do we do with it? Biopsy. Okay, biopsy. Is biopsy what you want to do? So first of all, you have to be very careful. You have to know what you're doing. One of the most common, probably the commonest, benign lesion in the liver is not of hepatocytes, but rather a non-epithelial benign tumor, hemangioma. If you stick a needle into this, you are going to kill your patient. Okay? So think, you know, you have to think what you're doing in these cases. But let's say and hemangiomas in the liver are really extremely common. The good thing today is we can do a CT scan. We know this. We do a CT scan with injecting contrast material, which shows enhancement in hemangiomas in a very typical pattern, so we can rule out that it's a hemangioma radiologically. Okay? And now we can biopsy. So we do a biopsy. Now what do we do with the biopsy? We have a piece of tissue. How do we make a diagnosis? Pathology. We do a section, and then what do we do? We stain with what do I stain?
Markers.
Which markers?
I don't know, for the mesenchymal.
Antibodies. Stem cell markers. What else? What else can we do? Regular staining. Hematoxylin and eosin. We'll talk about it. What else? Come on, we are in the Weizmann Institute of Science. Excuse me? Enzymatic activity, that's PCR. Genetic testing, right? Okay. Yeah, so, and we're seeing it more and more. A lot of companies are offering very fast and very expensive sequencing services. So the correct answer is that 170 years after Klebs and Virchow developed hematoxylin and eosin staining, this is still the most accurate way to diagnose most of the tumors that we're dealing with. It's extremely old-fashioned, but extremely efficient. And this is what we spend our time on looking at these slides. So why is it so efficient? It's better for most tumors today. Hematoxylin and eosin assessment of a slide section from a lesion is more accurate, still today, is more accurate than any molecular test that you can think of, than any computer-based system that you can think of any single marker that you can test with immunohistochemistry, with real-time PCR, but also better than RNA-seq analysis. So, doesn't make sense, right? But this is the case. What is the biological logic that underlies the fact that histology is such a powerful scientific method, scientific and clinical method?
Because the cells of the cancer are different from the cells you expect.
The cells of the cancer, why are they different? You know, they didn't become different so that I will be able to look at them and say you are cancer and you are benign. Why are they different?
They look different.
They look different, I agree, but why can we be so accurate in our diagnosis? Still, you know, medicine is something that is very fast changing, because, you know, the patients demand the best treatment that they can get, the best diagnostic methods, right? And histology is still the first line for diagnosis of tumors. Also other diseases, but mainly tumors. In other diseases, pathology is stepping down. How come morphology is so revealing? Chromosome multiplicity. So what I'm aiming at is to say that one of the fundamental principles. Excuse me? They try to imitate. Yeah, but you know, it's as much as we want to think of ourselves as important in nature. There is no biological process that is happening to try to please us, right? But what I'm aiming at is that one of the most fundamental unifying principles of biology is the structure-function relationship. And you see it at every level of biology that you look at how a protein is structured and how this structure is related to its function, a receptor and a ligand, the allosteric effects, the way a cell is composed, the organelles in a cell, the microanatomy of the organ, the anatomy itself. And when you look at the hand, it is very easy to say what it is doing. If you didn't have hands, you'd come from a world where organisms do not have hands, and you'd look at this thing and maybe see it just move once, you would know what it is supposed to do. And that is because of this unifying concept of structure-function relationship. And tumors have because they have a different functionality, maybe they're dysfunctional, that would be a better description, then their morphology is disstructured. And we diagnose tumors based on this structure. And we always have to take into account many factors. And maybe this is the second concept that I would like to convey about the work of a pathologist. It's never, our diagnoses are never based on a single parameter. They take into account multiple parameters. And I would want to try to plant into your minds two things to remember when doing your scientific projects. The first omics technique was histology. Okay? The first single-cell technique is not single-cell RNA sequencing, as people at the Weizmann could think. It's not even FACS, as many people in other places in the world think. It's histology. The power of histology comes from the fact that you get a lot of information from a single section, and you get it on single cells. And this is how we make our diagnosis. And it's not surprising, actually, that pathology can interact so well with methodologies such as RNA sequencing and single-cell RNA sequencing, because when you overlay this onto the tissue, you get a very, you can get important inputs on how it is occurring. Okay, so that was kind of trying to persuade all of you to come and do a residency in pathology. I'm not sure how practical this is. I do think personally that pathology is probably the most intellectually gratifying medical profession. We lose the patient care, that's true, which is even more gratifying than the intellect. But you can't win them all. So what do we do? I mean, so we did a biopsy, and now we have to decide, do we have a tumor-like lesion, a benign epithelial lesion, a malignant one, something that is not epithelial, and metastasis. And maybe at the beginning of this talk, I would say the most common malignant tumor in the liver are metastases, not tumors that originate in the liver. All tumors coming from the gastrointestinal system metastasize to the liver, and this is trivial. They do it through the portal circulation system. You know that all the blood supply, all the venous blood supply, coming from the stomach up to nearly the anus, goes first through the liver and then goes to the heart. So any malignant cell that detaches from these organs, the first place where it will be stuck is the liver. So it's not surprising that the liver is so commonly affected by metastases from the gastrointestinal system. Maybe less obvious is the fact that the liver is also a very common site of metastases for breast cancer, for lung cancer, for uveal melanoma, only site of metastasis. You know, when you have a tumor in the uvea, in the eye, the only place these tumors send metastasis to is the liver. Smart cells, you know, they can identify the best organ in the body. We don't know why. We have no idea why. This concept of why specific tumor cells metastasize to specific sites has been raised 250 years ago. We still don't know. There are many suggestions, but we don't know. So let's start, you know, with the less depressing things, tumor-like lesions. Really the best news when you have a liver nodule is what we call focal nodular hyperplasia, FNH. A lot of times these patients come with people from the, from other places, in other hospitals, other clinics, say you have a liver tumor. We see them and we say, forget it, this is FNH. FNH is practically a liver scar. It can be up to 5 centimeters inside, sometimes even larger. And you can see here, this is a liver, and you see this huge thing with a central scar, and it really looks like a tumor, but it's not. It's a benign process. It's reactive. It's not clonal. We don't find any mutations or so, and practically, if you know before the fact that this was resected is a mistake. Okay.
Could it be because the liver has such a regenerating power, where every little something will give you this type of accentuated growth?
Definitely, if you look at this thing, it's really it's practically a regenerative process. You see many proliferating bile ducts and many proliferating hepatocytes. We don't know what causes it. We have no idea what causes it, but we're happy to see. Anytime that we see it, we're happy. Good news.
It's still a hepatocyte.
The FNH, yeah. The FNH, when you, No, so I also have to prepare questions for the exams. I'm not going to ask you on FNH. I'm just showing it. I'm showing it as an example that reactive processes that are not neoplastic can form tumors. Maybe the commonest example, young, usually men, come with a extremely fast growing nodule in their arms. My cousin had it. And I can tell you, I was terrified, even though I knew what is the most likely diagnosis. There is obviously all the alternative ones. But so, and it grows like in 3 weeks from something that you don't feel to something that is 2 centimeters inside, very hard. What is it? It's a reactive process. Okay, nodular fasciitis. The patient comes terrified because the patient is sure that this is a tumor. But actually the fact that it is growing so fast and the site, the likely pathogenesis for nodular fasciitis is trauma. So it's a scar that is growing there for some reasons which we don't know. It's an exaggerated scar. But you remove it and it's gone. If you know that it is nodular fasciitis, you actually don't have to remove it. It will disappear on its own. So FNH, in a way, is a scar in the liver. It has a scar-like appearance. We have similar diagnostic entities in other organs, like in the breast. We have what is called a radial scar, and it's the same situation. It looks like a tumor to the radiologist. Their preliminary diagnosis is cancer. They do a biopsy, and we see a radial scar. And you don't need to do anything. There is actually in the breast, a radial scar is associated with a high risk of developing breast cancer, not even in the same breast. So again, things to understand here. I told you already before, the most common primary liver tumor and a benign one is the hemangioma. Usually, and a huge percent of the population has them, they are like very small, 1-2 centimeters, but they can be huge. Sometimes you can see a liver like this one. This is the entire liver, you see? And see how much of it is replaced by this huge hemangioma, which is benign. There is, of course, a malignant counterpart for hemangioma, which is called hemangiosarcoma. This is a very bad tumor to have, with really no treatment options. So how do we diagnose a hemangioma? We take a section, we stain it with hematoxylin and eosin, and you see that this tumor is composed of multiple small blood vessels. You see the blood within them, and they're all very similar, and they're not interconnecting. You see, you can, for each one of them, you can draw a circle. So there is no connection between this one and this one and this one. Obviously, there is a connection, right? So we make our diagnosis on 2-dimensional images of what is obviously a 3-dimensional process. But the criteria are established on this 2-dimensional thing. With hemangiosarcoma, one of the most important criteria to differentiate hemangioma from hemangiosarcoma is the fact that they interconnect. You don't see these very clear bridges between them. Another important parameter, which would be even more convincing, is when this starts to invade the adjacent tissue. This is actually an ectopic-like lymphoid structure, if anybody is interested to know. So there are also many types of hemangiomas. Again, I don't want to go into this. And now we're moving into maybe a more interesting epithelial lesion of the liver, which is the hepatocellular adenoma. And before I discuss the liver adenoma, I want to mention, you know, the concept of tumorogenesis as an evolving genetic lesion which is paralleled with evolving morphological appearance has become now one of the basic principles of oncology, right? So Clark was the first to describe this in melanoma, and he was the first to recognize that nevi, which are benign still, but have features that distinguish them from the real benign nevi, can progress into melanoma. So describing this spectrum of lesions that progress from benign to premalignant to malignant. And Clark was probably one of the smartest pathologists around, because in melanoma it is not very obvious when you look at it. But then obviously for colorectal cancer, many people noted before that adenomas in the colon can grow, can display more and more worrisome pathological features. Eventually you start seeing a benign tumor which is defined by being non-invasive, starting to invade the adjacent tissue and develop into a full-blown carcinoma, which can later on invade through the bowel layers, reach first the lymph nodes and then distant metastatic sites. And Bert Vogelstein was the first person to show that this morphological progression is accompanied by acquisition of more and more genetic lesions. Today we know that it's also epigenetic lesions and metabolic lesions that go hand in hand with this progression from benign to premalignant to malignant. And in some cases, we even understand the pathogenesis. Why does a benign polyp turn from a benign one into a malignant one, and in the bowel? And the answer is a mutation in which? P53, classic, right. So the first mutation which generates a benign lesion in the colon would be usually an APC mutation which activates the Wnt pathway, and this forms a benign lesion. In fact, it is even not enough to form a benign lesion. Other things must accompany it. But then secondary mutations, most commonly P53 and KRAS, induce the progression of the tumor. So what about liver? Is the liver adenoma similar to the colonic adenoma? And with colonic adenomas, we say that every adenoma of the colon, so I don't want to go into this, it's too many words, but the classical, the real tubular or villous adenoma of the colon, we say that all of them, even we call them benign tumors, but we believe that all of them have the potential to progress to malignancy. About 1 in 20 adenomas, if you leave it in place, will progress to malignancy. That's a high number, 5%. And in many patients, we see more than one. Okay? If you remove it, you cured the patient. This is the best preventive disease. Treatment. So what about the liver? Adenomas in the liver are more common in young women. HCC, the major liver cancer I'm going to talk about later on, is much more common in males than in females. So this goes against the notion that adenomas are the precursor lesion for HCC. They are often associated with long-term oral contraceptive use. In fact, most of the females with liver adenomas took oral contraceptives. Not common in males, obviously. So what is the most severe complication? The most severe complication is rupture Another severe complication is misdiagnosis as HCC. Physicians don't like to talk about their own mistakes, but it is difficult to differentiate a benign from a malignant, a hepatocellular adenoma from a very well differentiated hepatocellular carcinoma. We can spend hours on trying to decide, and most likely in those cases where we spend hours on trying to decide, our chances of being correct are about 50%. So maybe we shouldn't spend the hours, just need to decide, but that's how life goes. What about molecular diagnosis? So there are mutations. The HNF1 alpha is a transcription factor, which is important for liver identity. Beta-catenin, I'm sure you all know, is a major mediator of the Wnt signaling pathway. And they are found in some of these adenomas. These genetic lesions are associated, I just think I have a slide here. These genetic lesions are some of them are associated with a higher risk of transformation. For instance, the ones with beta-catenin are more likely to progress into adenoma, into HCC. Still, you know, in the current standard of care, we don't test liver adenomas for mutations, simply because if they have been removed, they're not likely to progress anyway. So, and we remove them. These are usually young patients with very minimal surgical risk. So how does this adenoma look? So this is the liver, and you see here a very large mass. Actually, there are two masses here. Most adenomas would be solitary, but we sometimes see cases where we see several. And I remember one case where we had hundreds of adenomas in the liver, all of them benign, and in a case of a woman that took oral contraceptives. So I don't know why her liver was specifically more susceptible to developing this tumor. When you look histologically on these lesions, they are composed of mature appearing hepatocytes, and one of the most differentiating aspects is the fact that there are only hepatocytes there, and we don't see bile ducts because it's an adenoma, it's not a normal liver. So if you see a mass in the liver without bile ducts, it's a tumor composed of hepatocytes. And now the question is, do we define it as benign or malignant? And it's a tough question. It's a tough question because HCC is one of those, hepatocellular carcinoma is one of those diagnoses which you do not want to miss. Not as important as meningococcal meningitis, but you do not want to miss it. So how do we do it? So this is a larger view of the adenoma, and everybody here who has seen histological slides of the liver would recognize that these are hepatocytes. And I don't want to turn you into pathologists, but I want you to get the feeling of how we make these diagnoses. And what we do here is we try to look at the trabecula of the liver. A normal liver is an exquisitely designed organ. You see these trabecula, which are always 2 cells thick. They're standing, rows of hepatocytes standing like this. Then there is a sinusoid, and they all are arranged in this octagonal structure, which allows the flow of nutrients and blood in a unidirectional way. And we know today that not all the hepatocytes are the same, but look at the adenoma. So when you look at it, you see you don't have these fine trabeculas that you see in the normal liver, right? The normal liver would look something like this. very straight, very parallel, everything looks the same. And here you see that it is disorganized. This goes for tumor, not for benign. But the other thing that you see is you try to define the thickness of the trabecula. And I know that most of you are not going to believe me, but I'm going to try anyway. So you look at this trabecula here. Is it a trabecula? To be honest, I'm not sure, but it looks like it. Okay? The joke in pathology is, what is this? I have no idea, but here comes another one. Okay? This is how we work. So if this is a trabecula, and maybe this one is also, and this one is also, and now you are starting to see them, right? They are now appearing all around this picture. And now everybody has to think, and think on your own. Don't, what is the thickness of these trabecula? Are they 1 cell thick, 2 cells thick, 3, 4, 5, 6? Not from here to here, but from here to here. So everybody pick a number, anywhere between 1 to 7. Think about it, and now you are making a diagnosis. Because this is probably the most important parameter. Okay, so everybody has made their own decision? Okay, so who thinks 1? 1, 2, 3, 4, 5, 6, 7. Who thinks 2? Who thinks 3? 4? 5? Okay, so it's called חוכמת ההמונים. I don't know what's the
Wisdom of the public.
The wisdom of the public. And you were right. This is a benign lesion. And if you see up to 1, 2, sometimes 3, this goes for benign. It's not sufficient to make the diagnosis, but it's one of the important parameters. Another parameter, and I'm going to show you after the break what happens in HCC. When we talk about HCC, we stain the liver with silver stain. We call it reticulin stain. These are methods which were developed in the early 1900s, trying to use many different types of stains. Silver stain attaches to the extracellular matrix. And it's, when we say silver stain, it's really made with argentum, silver. Argentum is silver, am I correct? Yeah? Huh? Okay. Maybe I'm wrong. Anyway, silver. So, so everything is very expensive in pathology, not really. And what you see is this very intricate network of extracellular matrix, which is deposited by the adenoma. This is very similar to what you see in a normal liver, where you would see exactly the same pattern. The only difference would be that you would see the very organized structure of the liver. So the lines would be straight and not so haphazard. And I'm telling you all this because the bottom line is, if we're developing these very wishy-washy types of criteria, it means that this is a difficult diagnosis to make. So when we will see a high-grade hepatocellular carcinoma, you look at it for 1 second and you say this is a malignant lesion. But the way, yeah, you will see them after the break. This is a teaser now. But the very well-differentiated ones are the ones where you can make the most mistakes. Okay? So I think I already mentioned this. The inflammatory adenoma is an entity that was quite recently described by Jessica Zuckman-Rossi from Paris. They're quite common, even though we missed them for many years. and they have quite a high tendency to progress to malignancy. So important to identify. I think we will stop now for a 15 minutes break, and the next hour is going to be dedicated to malignant lesions of the liver. And I just want to emphasize again what I told you before, that the most common malignant tumors in the liver are metastases. So, and it's not only important, you know, it's an important fact to know, but of course very important clinically. If you see something malignant in the liver, look for a different primary site. And what you see here are several. This is you know, in 1958 we used to do a lot of post-mortem examinations. This is from a picture from one of them. You see this huge metastasis, which is largely necrotic, very typical of metastatic lesions. Another liver from a post-mortem examination from 1960. You see 1, 2, 3 lesions. This very typical white, firm white lesion. This is very typical. You can't make a diagnosis, obviously, on this. You will need to do histology, but it really looks like metastatic colon cancer in the liver, one of the most common primary sites of metastasis to the liver. And here you see a more worrisome feature. And what if you look at the patient, what would you see? The patient, yeah, jaundice, right? You can see the jaundice. You actually see the bilirubin accumulating in the liver, which you didn't see here. So this patient probably did not die of liver failure, but this one maybe did die of liver failure, obviously because you see this jaundice. But what you also see, which is more worrisome, is you see multiple metastases, multiple sizes, some of them coalescing to form these huge masses, and it seems that the liver can no longer function with this huge disruption of the normal anatomy. So for the liver to function, it not only needs the mass, but it also needs the normal anatomy, this regular flow of blood along the course of the sinusoids. So you have to think, why are these metastases different in sizes? Are they any ideas? Different times, right. What else?
Different origins.
Different origins, right. So we know today, what we didn't know maybe 2 years ago, that metastases can form metastases. It's trivial, but needed to be proven. It's possible that this metastasis is the source of all these metastases, but of course it's also possible that all these are coming from the colon. And this is something that it's important. Why? Whether we should resect metastasis. Okay. So what do you think? Is it in colon cancer, when you find 3 metastases like here, there's probably another one here, is it worth resecting them for the patient? What do you think? Many microscopic, right. Is there anybody here who thinks differently?
Yeah.
What do you think?
That if you can resect without endangering the patient too much. Yes.
Yeah, so 20 years ago, most of the people felt like most of the audience, but today we know that Leah is correct, and removing single, double, or even triple metastases can prolong survival. So we're changing the way that we're looking at metastases. This is work mainly from France, David Azoulay, and then many others. So metastasis has now also become a surgical disease. But obviously here, there is no way you can use surgery to cure this patient. Both of them are dead, so there's nothing you can do. So, so we're going to the main culprit of today's talk, which is HCC, Hepatocellular Carcinoma. That's the malignant liver tumor that has a morphology of hepatocytes. I'm going to call it HCC from now on. There are other primary liver cancer which are epithelial, mainly bile duct cancer. I'm probably not going to mention it more today. HCC is the most common primary liver cancer. 90% of primary liver cancers are HCC. And the burden of HCC is increasing. The WHO has designated it the biggest cause for concern in cancer because of the rapidly rising incidence. And look at this curve. These are SEER data. So SEER is the database that is used from, I don't remember the number of states in the United States which have strictly controlled cancer databases. And when I say strictly, is strict not in the Mediterranean way that we call strict, but in the American way. So it's really strict. They know about every person in that country, whether he had or did not have cancer and what was the outcome. And these are the SEER, and they don't, not every American state is included. I mean, even there, they are very picky about it. So this is considered the best database to look at what's going on in cancer. And this is all Americans, you know, from all kinds and races. And you see this very rapid increase, which is unparalleled by any other major tumor type, right? We saw rapid declines in cervical cancer, stomach cancer, I think, is going up. Lung is going down. Why is lung going down? Because less people are smoking. Good. And if anybody in this room continues to smoke, put him up against the wall, and well, stop. Maybe that's better. So why? Why is liver cancer increasing so rapidly? Alcohol? No, alcoholism. It's true. So let's think about the risk factors for HCC. So alcoholism is a very important risk factor for HCC. We're going to discuss them later on, but I want to get an answer to this question first. But alcoholism is not rising. I think it is actually quite steady.
Our food.
Food. Industrial food. That's interesting. I don't know of data about strongly connecting industrial food per se with HCC.
No, I think it's a question.
Drugs? No. Fibrosis?
It's a question of we improved so much in diagnosis of other disease.
Sorry.
We improved so much the diagnosis of early other tumors, and the therapy improved, like breast cancer, leukemias, and so. So the oddity, the chances are really reduced statistically.
Yeah.
But not that there is a real cause for that.
No. So the thing is that the SEER database is corrected for age. So it's not as if people are getting older, so they have a higher chance of getting HCC. We're really seeing more HCCs. And one other thing I want to say, so for breast cancer, we know that one of the most important reasons for an increased diagnosis of breast cancer is better screening. So we're detecting now tumors which we would have never detected before and would have never done anything to the patients. Think about it. No, it's not funny. We are over-diagnosing patients. Definitely with thyroid cancer, there was this, I think it even reached the general news that we downgrade, not we, people in the, the experts in thyroid cancer downgraded one of the tumors from carcinoma to snippet. I don't remember what is the small thyroid nodule with lower incidence of malignance, something like that, which we used to call, until a day before this was decided, papillary carcinoma of the thyroid, which would never kill any patient because even though histologically it's malignant, it's a benign tumor. It doesn't kill the patient. So with liver cancer, this is not the case. HCC is a highly aggressive lesion, and you don't miss it. It's, it's not something that if you wouldn't have, it's not like prostate cancer, that, more people die with prostate cancer than from prostate cancer. Okay, so HCC it's not overdiagnosis. So the answer here to this riddle is that this is one hamburger, this is the second, the third, chips, dessert, ice cream, steak, obesity. Okay. Obesity. When I was a student, we used to say, I was taught that obesity is not, fatty liver disease is not a cause for HCC. Today we know that this was wrong. Fatty liver disease is rapidly becoming the most important cause, etiology, for HCC. And we are eating more and more, and with every kilogram that we're adding, we are increasing our risk to develop liver cancer. There are, excuse me?
Who is the red population?
Red population?
Which is the highest?
API. I think that I think these are Indians, but I don't know the Rashi Tevot.
But they are very fat?
Yes. They have a huge problem, because they only live in those reserves, and they live off, it's the only places in the States where you can gamble, so it's tourism, and their health state is terrible. So look at the world distribution of HCC. This is also very revealing, and I took here two pictures from two reviews. One from 2006, one from 2016. I am a co-author on this one, so I chose it just because it was. But you'll see the same in every place that you look at. So look what was the situation 10 years ago. HCC was very common in China and in sub-Saharan Africa. And the reason for that was hepatitis viruses, mainly hepatitis B in China and Africa. There's a burden of hepatitis C here. We'll talk about hepatitis C soon. It's an unanswered question. And in China, there is also this very close association with aflatoxin. So aflatoxin is a toxin that is produced by Aspergillus flavus. It's a mold that a white mold. That's why it's called flavus. It's very common, but you don't want to eat a lot of it. And the wheat in China is stored in humid areas.
Under the bed they store it.
Under the bed, I didn't know that.
Yeah, this is why they sleep on it.
Yeah.
The
And I didn't believe at the beginning. So, and it's associated with a specific mutation. So there is a P53 mutation, which is induced by the aflatoxin. and I really find it unbelievable. I discussed it many years ago with Varda and Moshe. How can a chemical detect a specific nucleotide in a 3,000 base pair genome? So the answer is it's not that specific, but it is specific. And the fact is that when you look at p53 mutation, we didn't have the data at those times, but today we do have the data. And when you look at p53 mutations in European countries where there is no aflatoxin, then we don't see this extreme predilection for this specific mutation which is induced by the toxin. So it is very smart, this toxin, and it can induce a very specific mutation. And actually today, when we, after this very beautiful paper from Mike Stratton and Ludmila Alexandrov on mutational patterns in cancer, everybody knows this paper? Good. So one of the, which carcinogen was discovered there? Aristolochic acid. Look back at the article. Everybody thought it's nonsense. Aristolochic acid is important about 1% of human cancer cases. People used to give it as medicine, as tea in Greece, I think, to cure whatever. And it causes cancer. So you look at this and you look what was in 2006, and you see that most HCC was in China and sub-Saharan Africa. Terrible for grants, you know, we couldn't get grants because who? But it's not funny. That's life. Yeah, I used to work on prostate cancer because of that. Yossi may remember those periods. But things are changing, because you see that while China and Africa are still high, we're seeing a dramatic increase of HCC incidence in the United States and in many places in Europe, France, but also Germany is now a country that infested by HCC. So what are the risk factors? Chronic viral hepatitis B and C, alcohol, fatty liver disease, as I mentioned, any cause of cirrhosis. And we mentioned aflatoxin B1. I mentioned smoking regarding lung cancer, but smoking is also important in the pathogenesis of liver cancer, bladder cancer, esophageal cancer, oral cancer, colon cancer, kidney cancer, and I forgot maybe, what did I? Cancer. Cancer in general. The only population which I know which is protected by smoking is BRCA mutation carriers that smoke have a lower incidence of breast cancer. The reason is,
They don't smoke.
no, they do. The reason is probably because of it has a hormonal effect. It reduces the smoking reduces the levels of estrogen, and tamoxifen is known to prevent breast cancer in BRCA mutation carriers. We don't usually say that aloud because it's a bad. If this is what you remember from my lecture, then I should be flogged when exiting the Weizmann Institute of Science. Smoking causes definitely is the biggest preventable cause of cancer in humans, far more than any other thing that you can think of. Probably the next would be eating too much. So eliminating hepatitis B is eliminating HCC incidence where people are immunized against, are vaccinated, against hepatitis B. With hepatitis C, there is a big question currently in the field, because one of the a revolution that is occurring in the treatment of liver patients is the availability of the direct acting antiviral agents. that are now available in the USA, in Europe, also in Israel. Very expensive drugs. The drug companies are making a fortune on them. You can see this in the liver cancer conferences, which have the food has become better. We're probably going to have more HCC, right? It's really disgusting the way this impacts the conferences. But so 98% of patients with HCV are now cured by these drugs. So there are first generation, second generation drugs. The early data showed that patients that take these direct acting antiviral agents have an increased risk of developing hepatitis C. Increased risk. So in the years after you start taking them, your risk of developing HCC increases. This was then debated, and people thought that this was just an observational effect because, you know, people were in studies, so they were more closely followed up. And so we don't know the data today. Nobody knows for sure. Do these DAAs, do they increase the risk of HCC? Do they decrease it? Or maybe it doesn't change despite the fact that we have cured the disease. And when speaking to people that are doing these trials currently, it seems that the last answer is the correct one. So these direct acting antiviral agents, while treating the disease, there is no hepatitis, the patients are relieved of the symptoms of hepatitis, the risk for HCC remains the same. So they must be continuously followed up. And there is something strange here, because how come the risk is not changing? If inflammation is so important in liver cancer, as I'm going to show you next, shouldn't reducing the inflammation have drastically removed the risk, as it does with hepatitis B, where you completely eliminate the virus? So if you have a good answer, you should study it.
I think the change is already there.
So one answer would be that there is already a tumor, but we should have started to see a decrease if this was the answer. If it would simply be that it just takes time for the disease to develop, so it's already there, but it just takes time, we should have started seeing this decrease. And this was what people said at the beginning, but we're not seeing it.
Is it becoming chronic or
No, it's cured. You don't find the virus. You don't, no RNA. It's an RNA virus. You can easily detect it, no RNA. But still the risk remains. I think it's immunological, but yeah. So what is the largest immunological organ in the body? The liver.
No.
Yes. The spleen weighs 150 grams, the liver weighs 1.2 kilograms. Even if the spleen has, let's say that the spleen has 50% immune cells, the liver has 20% immune cell, it wins by far. I don't know, you know, nobody.
As immunologists, we never study immunology
Exactly,
of the liver.
exactly.
We study immunology of the bone marrow, spleen,
Thymus, skin.
node.
But the lymph nodes, but the liver is a very important immune organ. It's not only the largest immune organ in our body, it's definitely by far the largest reservoir of NKT cells. 90% of the NKT cells in your body are in your liver. Nobody knows what they're doing. Nobody knows why they're there. Maybe they're there to combat HCC. We don't know that.
But maybe you know the question of so much angiogenesis, which you keep mentioning, that is the main claim for fame of the liver.
Yeah, so I'll just staying in the immunological field, and hopefully we'll have some time to talk about immunotherapy in HCC. When you do liver transplantation, unlike any other organ transplantation in the body, The only thing you need to care for is ABO matching. No, you don't need to match HLA. Did you know that? You don't need, you put a liver that is HLA mismatched into the recipient and it won't be rejected. No, in heart you do need. I wouldn't want a heart which is not, yeah. Okay. So, and the reason is that the liver is an immune privileged organ. So, oops. So this figure, the green ones are the males. The light green ones are the males. The dark green ones are the females. And basically, you can look in any country you want to look at. In nearly all of them, HCC is more common in males than in females, threefolds more common. There were several papers in Cell and in Nature trying to explain it. I don't think that any of them really know the answer. Prevention. So I mentioned reducing HBV load. The anti-HCV drugs, we don't know. Statin use when you reduce your cholesterol levels and when you drink coffee. You reduce your risk of HCC. No. Coffee, so I'm not an epidemiologist. A few cups of coffee, I don't know the number, are good for you. They improve your metabolism, they lower your blood pressure, they reduce your risk of several cancers. So the fact that the natives of America used to drink the coffee means that they were smart people. But too much, of course, is bad. But definitely there's lots of evidence tying moderate consumption of coffee with better health. Same goes for chocolate. Yeah. Chocolate. I wasn't chocolate, not. Sorry if I wasn't clear about this. Pre-malignant lesions. We were talking before about the adenomas, but probably the more common pre-malignant lesion in the hepatocyte is what you're seeing here, and maybe even more important is what you're seeing here. And these are areas, so you see the trabecula here, right? And 2 cells thick, right? 2 cells here, 2 cells here, 1 cell here. So this is not a malignant lesion by that criterion alone. But what you also see, compare this to this. Okay? So this would, what a normal hepatocyte would look like. These are very large cells with large nuclei. We call this large cell dysplasia. We often see them in livers which also have HCC. So they were thought to be a pre-malignant lesion. But this small cell dysplasia, where you see that the nucleus is occupying a larger percentage of the cell, are even more tightly connected with the appearance of HCC. Are these real precursor lesions? So it's debated. Nobody knows. So Jessica Zuckman-Rossi analyzed a lot of these adenomas for the presence of mutations which are commonly occur in HCC. And 6% of these lesions have telomerase mutations. Telomerase is the most common mutation found in liver cancer. So what does this mean? Does this mean that they are pre-malignant? I don't know. In my mind, they're not. But you know, this is just a personal opinion. I started writing something about this, but never finished. And when you read the literature, I don't think that there is evidence enough to show that these dysplastic lesions, either large cell or small cell dysplasia, are precursor lesions. What we can say for sure is that if you find an area in a liver with either small cell or large cell dysplasia, the risk of this person to develop HCC is increased. But are these the cells from which the tumor will eventually arise? We don't know. This is very different from most other organs, like in the breast, in the colon, in the lung, in the kidney. We know how the pre-malignant lesion looks like. There is no debate about it. Prostate. But in the liver, we don't. Same goes for brain. We have no idea how the pre-malignant lesion looks like. And this is, of course, problematic because it makes it more difficult to study the early stages of tumor progression. So what you see here is a patient with cirrhosis, שחמת של הכבד, and this is the typical morphology of cirrhosis with multiple nodules. This is what defines cirrhosis, the presence of these nodules. If you don't have these nodules, you do not have cirrhosis. But then you start seeing what we call dominant nodules, and you see one here, and you see one here, and you see this one here, and this is an artifact. Don't look at this circle. It's look here. You see that within this nodule, you're starting to see smaller nodules. So this nodule-in-nodule pattern, this is very worrisome. These are real precursor lesions for sure, because eventually we see them progressing into HCC. Okay? And here, sorry, and here you see. I think it's difficult to see. You see this, again, a cirrhotic liver. You see these nodules, which are not very easy to see. And here you suddenly see a nodule which is very different, right? This is not histology, this is morphology. And this histologically turned out to be an HCC. And this is the typical presentation of HCC. So most HCCs develop on the background of chronic inflammation in the liver. And most of those would be in cirrhotic livers. And this is a very interesting thing about HCC. It's the tumor which is most tightly connected with chronic inflammation. There are multiple causes of chronic liver inflammation. It can be viruses, there can be alcohol, there can be fatty liver disease, but also rare genetic diseases like hemochromatosis and tyrosinemia, and Ayelet can probably give you a much larger number of those. Any disease which is associated, which causes chronic liver inflammation, any disease is associated with an increased risk of developing HCC. So there is this very strong connection between chronic inflammation and HCC. Again, and the vice versa is also true. 85% of human HCCs develop in chronically inflamed livers. So there is this very, very strong connection, and many people are studying this. This is also what we study in our lab, and we're beginning to understand this relationship. It goes up and down all the time.
What's the cause of that?
Excuse me?
What's the cause of that?
The cause of the inflammation? So any cause, it could be, so in China, the most common cause would be HBV. In Russia, I would, well, I shouldn't have said what I wanted to say. In the US, it's fatty liver disease. Okay?
How is it connected? How is it connected? Why is fatty liver disease causing inflammation?
Why is fatty liver disease causing inflammation? So basically, the dogma is that when the liver is loaded with fatty acids, it can no longer metabolize them via beta oxidation, and this causes ER stress, and this ER stress is inducing reactive inflammation. The thing is, we don't know. So 30% of obese people will develop fatty liver disease. About 25% of those will develop inflammatory fatty liver, what is called steatohepatitis. Why do these, why the progression from the non-alcoholic fatty liver disease, which is fatty liver without inflammation, to steatohepatitis, which is inflamed fatty liver, is the most important event, because this critically increases the risk of both cirrhosis and HCC. So if we knew why NAFLD progresses to NASH, we would be in a good state. A lot of people are looking for this, for what causes it. So we know that there is increased ER stress, we know that there is impaired beta oxidation, but why a specific individual progresses while another doesn't, we don't know. And it's a big question today in liver research in general, not just in HCC, because cirrhosis is, you know, we're talking all the time about HCC. Cirrhosis per se is a very bad disease to have. I think the 5-year survival rate with just cirrhosis is less than 50%, I would say. I don't know the numbers, but it's bad. You don't want cirrhosis. It's a bad disease to have. It's okay, so I think I said all of this. And here you can see, so up to say, the thicker trabecula, more than 3 cells, loss of this reticulin stain, this silver stain, which I showed you before. And obviously, there are very clear signs of malignancy, which we use for every tumor. If we see tumor invading into blood vessels, or if we see tumor invading into adjacent normal parenchyma, this defines it as malignant. And you can see here, so this is, again, this is a very well differentiated tumor, right? You can immediately see that these are hepatocytes. Interestingly, you see that some of them are loaded with fat droplets. So there is this ER stress here and so on. But this does not mean that this was the cause for this tumor. And look at the trabecula. Do you see them? So I think that you can see one here. And it's 1, 2, 3, probably 4 cells thick. You can see this one here, this one here. Would you believe that this is how we make diagnosis for patients? This is, but some cases.
Any specific staining?
So we have
Ki-67 something.
Ki-67 has not proven effective in differentiating benign from malignant in any place. We do use it to define grade, like to define low grade or high grade, we use Ki-67, but not to differentiate benign from malignant. In fact, reactive lesions often show extremely high rates of cellular proliferation, and they're benign by definition. So it cannot be, at the beginning, there was a lot of hype about using BRDU. People were injected with BRDU, human patients, like we do with mice. It wasn't toxic at all. Here, I think it is much more obvious, right? You see the trabecula. Nobody doubts that these are really thick. And here, they're actually like 10 cells thick. But here, you also start seeing something. Something else, and which is even more pronounced here. And here you see what pathologists like to talk most about, and that is dysplasia. These are the morphological characteristics of highly malignant cells. Okay, and what are they? So a normal liver nucleus would look something like this. This is malignant, but this is like the most normal that you see here. And now look at the spectrum of nuclei that you're seeing here. And this is pathological. This, when you look at the section and you see a high degree of dissimilarity, this makes it, this raises a flag, malignant, okay? It's very easy to say, it's more difficult to quantify. Computer systems that are trying to use this as a criterion often fail because there are some things that we cannot convey. But when you look at a cell like this, that is mostly a nucleus, which is very large, and one here, and one here, and one here, and this degree of this similarity, this is pathological. And this is a higher grade HCC. And now look at the silver stain for this tumor. So this is the adjacent normal liver, and this is the tumor, completely devoid of extracellular matrix, which is stained with this silver stain, suggests it is malignant. This is a soft criterion. It's not a strong criterion. But this is how we work. We add criteria. So some criteria are very strong. Vascular invasion. You don't need anything more. If you see vascular invasion, it's malignant. In the case of liver, there are very weird benign tumors which can invade blood vessels, but not liver. If you see invasion, blood vessel invasion in the liver, it's malignant. Here you see another example, very high grade tumor, right? You see the nuclei are strange, the chromatin is clumped. Definitely, you see this, you don't need anything else. This is a hepatocellular carcinoma. Sometimes HCC forms gland-like structures. Again, definitely malignant. And here, this is like the extreme variant. This grossly looking thing here is a cell, okay? So this is a very high-grade malignant tumor. No doubt that it's malignant. The only question one would ask here is whether this is HCC. Maybe it's angiosarcoma. It can also look like that. So you look in other places. You use markers.
This is a primary tumor, or can be also metastatic?
Could be metastatic, but if it's HCC, then it's a primary liver tumor. But this brings me to the question of metastasis. So liver tumor. The most common site of metastasis of HCC is the liver, right? A tumor can metastasize within the organ. Lung cancer often metastasizes to the other lung. So the liver is the most common site of metastasis. You see very nicely in this diagram the vascular invasion, which you can see, and but also the liver HCC can metastasize to the lungs and many other sites. Cancer cachexia is an important cause of death. Variceal bleeding from blood vessels in the gastrointestinal tract are a common cause of nasty death in these patients, which is the result of the combination of cirrhosis, which causes increased blood pressure in these vessels, and the fact that there is liver failure, so that the coagulation system is deficient, so you can't clot your blood, so every tiny tear in these blood vessels results in massive bleeding. Liver failure, of course, is an important cause of death. The 5-year survival is very low. So I have 3 more minutes. So this slide shows how nicely things have progressed with melanoma. This is a beautiful slide, really beautiful. When when I go into the taxi and make the mistake of saying that I'm a cancer researcher, and they ask, so why aren't you beating cancer? I should have this as a card in my pocket. Beautiful slide. What's with HCC? Not so beautiful. And this is actually, when you talk to the clinicians, this is very optimistic. Sorafenib is the first line, either resection or chemoablation, like local treatments. But the first drug that was, and until very recently, the only drug that was approved in HCC and for all patients without any biomarker is sorafenib, which is a multikinase inhibitor and does very little. And and it's a very toxic drug. There are now second-line treatments for patients that cannot take any more sorafenib or that it never helped them. But we're doing very bad on treating HCC. I think I would stop here and leave time for a few questions if you have them. And if anybody is interested in other types of liver cancer, then maybe you want to read the very interesting story about fibrolamellar carcinoma and how the unique translocation, which signifies it, has evolved. It's a touching story. Fibrolamellar carcinoma. Maybe let's show it here if anybody is interested.
Where are the mutation? You mentioned melanoma, 900 different mutations. Where are the mutations?
Yeah, okay. So that's obviously a good question, and there are several articles out there. And so there are the obvious ones and the ones that are more interesting. Obvious one is, so the most common mutation, I don't know why it's not shown. This is from the TCGA Cell paper by Anthony Wheeler a year ago. I can't see the TERT mutation here, but that's the most common one. I don't know why it's not in this figure. The reviewers have done a bad job. But this is the 40% of HCCs would harbor a TERT mutation. Maybe this is only encoding genes. P53, not surprising. Beta-catenin, not surprising. Next one is albumin. This is surprising. Mutations in albumin which result in lower expression of the albumin gene. And this is 13% of HCC have mutations in albumin. This, nobody knows why. The hand-waving explanation would be, why would a malignant cell bother to produce 30% of the RNA in the hepatocyte, the most common, and maybe 30% is an exaggeration, but the most common RNA and protein that is produced by a hepatocyte is albumin. Does nothing for the HCC, of course. The HCC does not care. So maybe there is a metabolic advantage in losing such a huge energy load on the cell. Is this really the answer? I don't know. Nobody knows the answer. I'm not sure that it's the answer, and I'm not sure this is the answer. Because in many HCCs, albumin is not expressed. Alpha-fetoprotein, which is the earlier variant of plasma carrier, is expressed by many HCCs. So I don't know. Auxin goes again to the beta-catenin pathway. Another thing that I want to point, so there are some mutations that go to inflammation, IL-6 and so on, but very interesting. And again, we have no idea why, not in this tumor and not in any other tumor, are recurrent mutations which are very common in epigenetic genes, ARID1A, ARID2, and there is another one which I cannot find. So HCC was one of the first tumors where we saw the surprising finding that epigenetic modifiers are lost recurrently in tumors. I think that in astrocytoma, we know that this metabolic derangement causes epigenetic change, and it was suggested that the reason that this is oncogenic is because of it induces an upregulation of, I think it was the FGF receptor. I'm not sure about that explanation. I think we still don't know how these epigenetic changes, which also occur in other tumors, like MLL in leukemia, is the oncogenic in some of the acute leukemias, is an oncogenic event, and it's an epigenetic modifier. Probably means that epigenetics is important, but I come from Jerusalem where it definitely is important. Hmm? Yeah. Okay.
Do you know anything about the results of in ACC?
Leah wants to ask something? Yeah?
Yeah, I can ask you later.
Okay.